So this is ABGs, and we're going to learn how to decipher these completely in this lesson. So the whole goal of the buffer system is to get the pH to stay normal. So we have chemical buffers in the body, things like bicarbonate. We have the respiratory system, which can help with buffering by either retaining or getting rid of CO2. The cells themselves are able to buffer to a very small extent, as well as the kidneys. We have fixed acids in the body. Now, fixed acids are metabolic acids, and they are acids produced from every other part of the body except carbon dioxide. And then we have non-fixed acids, and the only non-fixed acid is carbonic acid, which is a derivative of CO2. So these are the normal blood gas values. There is no way you're going to be able to decipher blood gases unless you memorize these, so you just kind of have to do that. Here are some things that you need to think about when you do ABGs. The whole goal is to get the pH back to normal. The body doesn't care what the numbers are as long as the pH is normal. The body will never overcompensate, so when it tries to fix an acid-base problem, it will not store up extra to use at a later date. It doesn't do that. Other things to remember is CO2 is a weak acid, but it's an acid, and bicarbonate is a base. So if you have a lot of CO2, your patient tends to be acidotic. And if you have a lot of bicarbonate, your patient tends to be alkalotic. So the first thing you're going to do is look at the pH, okay? If it's not normal, you then have to go and look at the PCO2 and the bicarbonate. If only one of them is abnormal, then you have plain, straight, old-fashioned, non-compensated ABGs. And you can really only look at Rome and use that respiratory opposite, metabolic, equal thing if it's uncompensated. Otherwise, you're going to maybe get yourself a little bit messed up. But later on in this, I'm going to show you all the steps you need to go through in order to determine whether the blood gases are acidotic, alkalotic, whether it's fully compensated or partially compensated, or if it's just normal. If it's not normal, the first thing you're going to decide is if it's alkalosis or acidosis. Then you're going to look at the PCO2 and then the bicarbonate and decide which one is the culprit. So a person with a high PCO2 or a low bicarbonate has acidosis. And a patient with a low CO2 or a high bicarbonate has alkalosis, okay? When we start to talk about compensation, what we see is the body's trying to move that pH away from the abnormal value towards the normal one. It will begin to compensate, and it will only be satisfied when it's within normal limits by a little bit. Now, even if the pH is normal, you still need to look at the PCO2 and the bicarbonate and decide which one of them looks most out of whack. So remember, a high CO2 or a low bicarbonate causes acidosis. A low CO2 or a high bicarbonate causes alkalosis, okay? Fully compensated means that the CO2 and the bicarbonate are both abnormal, but the pH has returned to a normal range. And what you're going to see is if this is the case, the pH will be like 7.35, maybe 7.36, or 7.45, or 7.44. It will be just within that normal limit. So you're going to make sure you check everything, the pH, the PCO2, the bicarbonate. You're going to look at the values and compare them and check for compensation. So other things to consider is an Allen's test. Now an Allen's test checks for patency of the radial artery. If you're going to stick a needle into someone's radial artery, what you want to do is be certain that the artery on the other side of the wrist, the ulnar artery, is working well enough to compensate in case you mess up. So when you do an Allen's test, you occlude the blood flow to the hand on both sides. So you compress the radial artery and you compress the ulnar artery, and you wait until the hand turns like whitish or bluish, okay? And then what you want to do is you want to keep your fingers still compressed on the radial artery and let go of the ulnar side. And if the hand returns to normal, then you can be assured that should something happen to that radial artery, the ulnar artery will take over and you won't lose circulation, blood flow to that hand. Also, things to think about is that post-procedure, this is an arterial stick. If it's done in the wrist or in the groin, it needs to be held for at least 5 minutes in order to retain homeostasis. Otherwise, it's going to bleed. You want to make sure that your patient, if they're on heparin or Coumadin or any other kind, or Lovenox, any kind of blood thinner, that the bleeding stops to that site that you've punctured. So respiratory acidosis, this is probably what we'd see most commonly, because anything that causes the patient's respirations to be decreased or depressed will cause respiratory acidosis. So COPD patients, patients with neuromuscular disorders like Lou Gehrig's disease or multiple sclerosis, patients who have respiratory-centered depression, lots of times it's because we've given them too much narcotic or if they've had a head trauma. Patients with central nervous system lesions or spinal cord injuries, people who have conditions where there's excessive carbon dioxide production. Those are when we'll see patients develop respiratory acidosis. What you'll first see with respiratory acidosis is that the patient has trouble breathing. They'll get short of breath, have difficulty, they become disoriented, maybe a little air hungry, and then they lose consciousness because they're not getting enough oxygen. And then dysrhythmias start, and we end up with cardiac problems. So we see respiratory acidosis. You'll see it in patients when their pH is less than 7.35 and their PCO2 is greater than 45. You also will see patients develop respiratory acidosis if they have hyperkalemia and hypoxemia. And the whole management thing is to get rid of the CO2. So we might see patients, if they're ventilated, we could put them on a ventilator and increase their respiratory rate to blow off some of that CO2. You can also see respiratory alkalosis in hypoxemic patients, people have impaired lung expansion or have thickened capillary membranes. If we have a reason for a patient's respiratory center to be stimulated, maybe they have a brain tumor or maybe they are on a ventilator, you'll see respiratory alkalosis. Or if they've had traumatic stimulation of the respiratory system because of a head injury. What you'll see in this patients is they'll have rapid breathing. They become giddy, which is silly. They kind of giggle and are inappropriate. They may complain of dizziness or syncope. They may have convulsions or coma, complain of weakness or paresthesia. So numbness and tingling you'll see in their hands. You see a lot of patients with respiratory alkalosis might be patients with anxiety or who have panic disorders. We see the normal values here for respiratory alkalosis. If it's greater than 7.45, the pH and the PCO2 less than 7.35. And you'll also see it in patients with hypokalemia and hypocalcemia. It's kind of hard to do respiratory alkalosis, but if we can get the patient's breathing to slow down, we find that that is something that really will help. So metabolic acidosis, you'll see that in patients who maybe have diabetic ketoacidosis or a buildup of lactic acid. What you'll see happen is that automatically, almost instantly, the patient will begin to hyperventilate, and that's because the respiratory system can compensate much more quickly than the kidneys can. They will become drowsy, may complain of a headache. We see the values for metabolic acidosis less than 7.35. bicarb less than 22. You'll see it in patients who have hyperchloremia with a base deficit. Metabolic acidosis is difficult sometimes to treat. We find it a lot of times we'll try to treat it with a bicarbonate, but bicarbonate is a kind of a medication that is difficult to control. And so sometimes you'll see what happens is we overshoot correction and we have the patient develop metabolic alkalosis. Just the opposite of that is metabolic alkalosis, and a lot of times we'll see metabolic alkalosis with prolonged vomiting, hypovolemia, diuretic use, and hypokalemia. People who take in too much bicarbonate or who we've given too much bicarbonate to correct another problem. The patient begins to breathe slowly to start to hopefully retain some acid. They'll develop dysrhythmias. They will also have hypokalemia and hypocalcemia. And we see these patients develop a bicarbonate that's greater than 26 or more. These are some more acid-base or ABG games to play in order to get familiar with this. Okay, now we're going to reach the point where we're going to try to pull apart ABGs and try to figure them out. So what I need to tell you is you need to be patient and you need to go through all of these steps so that you're certain that you're making the correct conclusion. So when you look at a set of ABGs and you look at the pH and you see it, the first thing you should do is look at the pH. And if it's normal, you've got two choices. Either everything's okay and has always been okay with your patient and there's not a problem and there's never been a problem, or your patient's had a problem and they have been able to fully compensate for any acid-base problem that they had. If the pH is abnormal, you've got two choices. Either the abnormality has just begun and there's no compensation going on, or the abnormality has been going on long enough for the body to begin to try to correct itself. So we're going to start with an abnormal one. So the pH is 7.30, the PCO2 is 60, and the bicarbonate is 25. So the very first thing you need to do is to look at the pH and determine if it is too low, too high, or normal, okay? So in our case, the pH is 7.30, which is too low, which means that the patient is acidotic, okay? All right, so we're going to continue to evaluate the patient even if we were to look at this and see that the pH was normal. So you're going to have to continue to the next step. After you've looked at the pH, you're going to look at the PCO2 and you're going to determine if it's high, low, or normal. So you're going to ask yourself this question: does fill in the blank, high or low, PCO2 cause fill in the blank, acidosis or alkalosis? Remember, from the last slide, we've already determined that the patient in our example has an acidotic problem. Now, the thing to remember is that CO2 is an acid. So if CO2 is too high, then you're going to have a respiratory problem. If a CO2 is too low, then there isn't a respiratory problem. So we look at our PCO2 and we see that it's 60. So I'm going to ask myself, does a high PCO2 cause acidosis? And the answer is yes, it does. So I somehow have a respiratory problem. So the next step is to look at the bicarbonate and determine if it is too high, too low, or normal. And you're going to do exactly the same thing, only this time you're going to substitute CO2 for bicarbonate. Or bicarbonate for CO2. So you're going to ask yourself, does a high or low bicarbonate cause either acidosis or alkalosis? So things to remember is that bicarb is a base, okay? So you're going to look, in our example, we have a bicarbonate of 25. So and that's normal. So does a normal bicarbonate cause acidosis? No, it doesn't. So you don't have a metabolic problem. You have a respiratory problem, and it's respiratory acidosis. Because the pH is abnormal, and the bicarb is normal, there's no sign of correction, okay? So this is uncompensated.